Hello, hello, everybody. Good morning, good afternoon, good evening, depending where you are located. We can see that you're coming in. If you want to, please use the chat function to let us know where you're joining us from. We are delighted that to welcome you today to our webinar titled From Drawing Board to Lived Experience and Back, Co-Producing Language Justice Infrastructure to Advance Health Equity. My name is Analia, and I am the manager of training and curriculum here at Cross Cultural Communications, the largest international training agency for community, educational, and medical interpreting. I will be your host for today's 1 hour webinar. Also, with us today and behind the scenes is my colleague Andrew Hall, Cross Cultural Communication Publications Manager. Andrew will manage the chat and will provide useful information throughout the webinar. Now, before we begin, and as we wait for everybody to join us, I see some people from Canada, Texas, Florida. So as we wait, just for everybody to join us online, I would share some CCC updates. On March 9th, CCC will host our second live training of the year titled Interpreting in Orthopedics, Introduction to Physical Therapy. Please go to our website learned.tci.net to sign up and take advantage of the early bird, definitely. And Andrew will post the link on the chat. Also, registration is open for our upcoming training of trainers. If you are interested in becoming a license to deliver the Community Interpreter International, the next online session is just around the corner, March 18th. So I would love to see you there. Okay, now I will go over a few points regarding the webinar. This webinar presentation will last about 40 to 45 minutes, followed by a 15-minute to 20 Q&A period, during which you can ask our presenter any questions. During the webinar, please keep the Q&A feature open and use the Q&A to submit questions to our presenter. For other comments or questions for us here at Cross Cultural Communications, please use the chat feature instead. And if you want everyone to see your comments in the chat, please make sure you set the chat to everyone. Lastly, if you want to stay after our presenter leaves at the end of the hour to chat with Andrew and me, if you have any questions at all about CC, cross-cultural communications, Blue Horizons, we'll be happy to stay with you after that. Okay, I know this is very important and we're so pleased to always do this. So this webinar has been approved for CEUs. Please remember 24 hours after the webinar, attendees will be emailed a link to download the certificate of attendance. Also, the slide presentations will be provided to you as well. So we're really, really excited about that. We want to remind you that if you, when you go to your email, that you will receive the certificate of completion to the same email that you used to register for this webinar. Please be sure to check your junk or spam folder if you don't see it right away within 24 hours. And again, the certificate will be available for 60 days after the session today. So please make sure that you download it by then. Now, without further ado, I would like to introduce our speaker for today. Again, the title is From Drawing Board to Lived Experience and Back, Co-Producing Language Justice Infrastructure to Advance Health Equity. So let me tell you about our speaker. Her name is Vanessa Costa. She's a Senior Director of Quality and Member Engagement for the Healthcare Interpreter Network, a collaborative of health systems that share interpreter resources. Prior to her current position, Vanessa was a director of multicultural affairs and patient services at Cambridge Health Alliance, named the #1 hospital in Massachusetts for health equity and community benefit by Lund Institute. Okay, lastly but not least, prior to her work at the Cambridge Health Alliance, Vanessa was a director of the Cross Cultural Communication Institute at CCC's Inc., where she specialized in curriculum development for interpreter and provider training and lecture nationally on topics related to intercultural communication and language access. Vanessa is also a member of the NCIHC Outreach and Membership Committee. She is a core certification healthcare interpreter, credentialed by the Certification Commission for Healthcare Interpreters, and has served as a CCHI commissioner since 2020. So, Vanessa, we welcome you in. The floor is yours. We're thrilled to have you here today. Thank you so much again, before you even start, for sharing all your knowledge, your expertise. I am going to disappear, Vanessa. The floor is yours. Thank you.
Thank you so much, Analia, and thanks to the 403 folks who signed up to attend this event live, and to the many who will watch it later. One moment as I pull up my slides, which will form the basis of our conversation. Hopefully you can see the title slide, From Drawing Board to Lived Experience and Back, Co-Producing Language Justice Infrastructure to Advance Health Equity. So who's in attendance? I know we have many interpreters, we have language access advocates, we have hospital language access program administrators, we have folks that work in compliance and patient safety, we have clinicians. Pretty much this is a webinar for anyone interested in advancing health equity in their community and in the organizations, the healthcare organizations in which they work and in which they receive services as patients and community members. It's really wonderful to see that there are so many like-minded folks who have, language justice, language access, and health equity as their focus. The conversation is going to center primarily around healthcare in the United States and the language access landscape here. I know we have international folks here in attendance. Some of you may be supporting language access for US hospitals. Others might be traveling back and forth, or you might be thinking of your own local communities. How can we do this in Canada? How can we do this in Brazil? How can we do this anywhere where there are linguistically diverse communities? So I've got my slides up and I'm able to advance them. Fantastic. So let's start with the hospital language access landscape. What does it look like out there in the US? Well, we know that the number of patients who receive care in languages other than English has increased significantly over the past decade. We also know from the most recent data available that still, even today, nearly 1/3 of US hospitals fail to offer language assistance services. 1/3. We also know from the most recent data available that even in hospitals that have built language access infrastructure, they have their programs in place, still more than half of all medical communication with patients and families who require care in languages other than English is happening without professional interpretation. How is that possible? Well, it's happening through English communication. It's happening through bilingual clinicians who may or may not have been vetted. It's happening through ad hoc interpreters. Maybe these are folks who work within the health systems. Maybe these are folks who come with the patients. So lots of different ways in which clinicians are communicating with patients whose primary language or language of care is something other than English. Lots of different ways outside of the utilization or the collaboration with professional healthcare interpreters. We also know, and you might have experienced this locally, or maybe you've read about it or you've heard about it at an interpreter conference, that in recent years, many hospitals have begun to downsize their in-house language access programs, doing away with in-person interpretation, outsourcing language access wholesale. This is a trend, and it's happened in many parts of the country. Um, if you have the opportunity, I really encourage you to take a look at the article here that is listed as a reference. It is a healthaffairs.org article from August 2016. And 2016 was 8 years ago, but it still has the most recent large-scale data set on language access in general hospitals. And it talks about a survey of 4,500 general hospitals in different parts of the US. And the results of that survey showed that the majority of private, not-for-profit hospitals did offer language services, but majority could be anything from 62 to 70%. So still a third of US hospitals did not offer language assistance services. It also shows that only about 18.5% of private for-profit hospitals were offering language services at any need level. And government hospitals, surprisingly, offered services at a rate that was more similar to the for-profit hospitals than to the nonprofit hospitals. So we see here huge gaps in the language access infrastructure in US hospitals nationwide. Lots of work to do. Now, in the past 8 years, we have seen examples of some hospitals that have invested and have begun to build better language access infrastructure. But we also saw going into the pandemic that hospitals that didn't have solid infrastructure in place struggled more. It was very hard to build something new or better or that works for the community during a time of scarce resources. So very, very interesting now thinking on the other side of, now is an opportunity, a moment of calm, perhaps a moment between pandemics where we can double down and look at where are the gaps in our infrastructure? What do we need to build now in advance of the next crisis? What do we need to build now that will help us keep moving forward and not backwards in our pursuit of health equity for all of the populations within our linguistically and culturally diverse communities? So that's the state of the state for US hospitals. What about clinics? Are clinics doing better? Well, there is a 2018 article here, springer.com, that looks at a survey of 273,000, almost 274,000 ambulatory physicians working in clinics across the country. And the survey asked them many things about their communication practices, how they communicate with patients in languages other than English. Uh, Most of the physicians reported that they frequently utilized bilingual staff and family members of patients for interpretation, and nearly 40% said they had never worked with a professional interpreter. Never. They also gave really interesting data on the availability of translated written materials. About half said, yeah, our clinics offer some translated written materials. About a quarter said, well, I think we have advanced directives in some languages. About 20% said, well, we do care plans in some languages. But more than a third said, I don't think we have translated materials in this clinic in any language at all. So the same gaps we see in language access infrastructure in hospitals, well, we see those gaps in clinics and ambulatory services throughout the country as well. So, you can look at this in different ways. You can say, wow, this is really bleak. The challenges are staggering. The challenges are insurmountable. Or you can look at it and say, wow, this is pretty bleak. Look at a tremendous opportunity to build better. It's an opportunity, and it's also something that compels us. It's really imperative that we focus on language access as fundamental to health equity now. The president of the Institute for Healthcare Improvement recently said that there can be no progress on healthcare quality without progress on health equity. And we know that language access infrastructure is essential in the pursuit of health equity in any community. Um, I think one of the most powerful quotes I've read recently on building language access infrastructure comes from Andrea Escalera. She's a worker in the Center for Health Progress. And she's a community activist, an immigrant, a heritage speaker of Spanish. And what she said was, there can be no health justice without language justice. And she continued, she said, our health system continues to prioritize profits over people, and healthcare executives are padding their own pockets at the expense of non English speaking communities. And then note what she said next. We need to be the ones determining what meaningful access looks like. We need to be the ones determining. We, the people, we, the community members, we, the end users of language access services, need to be the ones determining what meaningful access to healthcare looks like. And I really recommend checking out the Center for Health Progress website, and you can see several essays by Andrea on health equity in immigrant communities. And they do keep touching on, no health justice without language justice. And we, the people who utilize the services, need to be the ones who determine what services are made available and what meaningful access looks like. So we need to be the ones determining. That language makes me think of co-production. Co-production is something that clinicians are thinking about now, that hospital administrators are thinking about now, not just in relation to language services, but in relation to the entire healthcare system and how it's structured and what changes might need to be made to make it more accessible and more useful and more meaningful to the patients who receive the services. Uh, Co-production, according to the Journal of Ethics of the American Medical Association, it can be used as a means to rethink how healthcare is delivered, not only in the context of face-to-face encounters in which the benefits of working together are obvious, but also in designing systems that can improve patient care and enhance value. So co-production is beneficial in designing systems, but what exactly is co-production? Well, let's take a step back and look a little bit at the history of the clinical focus on patient partnerships. Hippocrates, the very famous father of medicine, said that the physician must not only be prepared to do what is right, but also to make the patient cooperate. And in modern times, make the patient cooperate does seem a bit dogmatic. It doesn't seem very inviting. But I think it's interesting that as far back as Hippocrates, clinicians realized that what they do is not going to work without the patient's support, without the patient's cooperation, without some level of patient partnership. Now, fast forward to our times, patient-centered care is something that we've been thinking about a lot. The Institute of Medicine has named patient-centered care as one of 6 domains of healthcare. So, we still are focused on patient partnerships. We may look at that now from a different angle, but fundamentally, healthcare cannot be successful without the support, the collaboration, and the partnership of the people receiving the care and participating in the healthcare experience. There are mounds of empirical evidence today that prove that informed, engaged patients do facilitate good health outcomes at a lower cost. So patients are facilitators of good health outcomes, but a lot depends on how we engage them in the healthcare process, all the way back to the design of the healthcare system. Because we know this and because we have evidence that proves it, today's payers are looking at healthcare consumer evaluation of their patient experience as a way of measuring and paying for value. So you may have heard of paying for value and not for service. Payers are surveying the healthcare consumers and asking them to rate their experiences with our healthcare institutions. And their ratings, to some extent, can determine the compensation that the institution receives from the payer, whether or not they are providing value in the eyes of the patients is now tied to their reimbursement and to the financial incentives. So we've come a long way from Hippocrates, but still there is a focus on patient partnerships. And today that focus is translating into things like reimbursement. So if we're looking at patient partnerships, we need to look at the fundamentals of co-production. Dr. Maren Batalden and her father, Dr. Paul Batalden, are two clinicians who have pioneered the concept of co-production in the design of healthcare systems. And they've written about this for the British Medical Journal of Quality and Safety. You can check out this article. It is a 2016 article. And they talk about the need to ditch the product paradigm. What they're saying is that healthcare, we need to stop viewing it as a product that we manufacture for the public, and we need to start viewing it as a service. So, what's the difference between a service and a manufactured product? Well, a service is always co-produced by service professionals and by service consumers. And so we can think of healthcare as a service in terms of experience. The patient experience is a co-production that involves the professionals, the clinicians, and it also involves the consumer of that experience, the patient. Um, Thinking of patients as consumers is not really capitalist. The word consume has two Latin roots. One of them that we use more often is to use up, to consume, or even to destroy. And that is a more of a negative connotation in some people's minds. But the other Latin root of consumer is to complete or perfect, to consummate. And so we really need to start thinking of patients as consumers in that they complete, they perfect, they consummate this experience, particularly when we tap into the value they add in the research, in the design, in the implementation, in the delivery, in the monitoring, and the quality evaluation of the healthcare systems that we are building, not for them, but together with them. So co-production is building together, not building something prepackaged and offering it to the public. Very interesting. So it is potentially revolutionary, and there are folks working in quality in different areas of probably your local health system that are now beginning to use the fundamental principles of co-production and inviting patients to design the healthcare systems and to build them together with us for their benefit, for our benefit. There are doctors who are writing about this, and in an article in the AMA Journal of Ethics, Pooja Tarakia and Brandon Combs, they said, viewing patients not as users and choosers, but as makers and shapers can allow for planning and implementing new policies that lead to better health outcomes and better patient experiences. So think about that in your own practice, whether you are an interpreter, a language access administrator, an advocate. How are we thinking about patients? How are we talking about patients? Are we viewing them as users and choosers or as makers and shapers? And if we do view them as makers and shapers, how are we inviting them in to the process of making and shaping and building? So, to recap, co production really does mean involving the end users in the planning, in the prioritizing, in the design, in the delivery, and in the assessment of what was built in relation to any health system, including language access systems in healthcare. Uh, Co-production has been utilized in the public health systems in the European Union, in the UK. This particular article that's referenced here is a 2013 article out of Scotland. It's called Co-Production of Health and Wellbeing in Scotland. And it looked at how the government, which runs the health service, involved the people of the communities in designing certain aspects of the delivery system and what the result was. And they found four benefits. They said when you involve the end user in the design of the service, that it employs their expertise. It ultimately enables more differentiated services and more choice for the consumer. It increases a system's responsiveness to the needs of the people, the consumers, and it reduces waste and cost. And these are great goals to have as a healthcare delivery system. Being able to offer more choice at lower cost and with less waste, who wouldn't want to do that? It can be done. It has been done in many aspects of health system delivery, and it can also be done in language access program delivery. So in looking at co-production, the medical community is now looking at people with lived experiences. Um, Robert Bate, in a 2007 article called Bringing User Experience to Healthcare Improvement, he talked about, experience-based co-design as a framework that invites focused attention on the lived experiences of patients, their families, and the health professionals who support them, and encourages collaborative work on health system redesign. Now, that 2007 article was really key, and it started many movements within healthcare, including what led to the 100 Million Healthier Lives Initiative, which was convened by the Institute for Healthcare Improvement and funded by the Robert Wood Johnson Foundation. This was a national initiative that ran from 2014 to 2020, so right up into the pandemic. And it was all about transforming how we think about health, well-being, and equity. Now, this project, 100 Million Healthier Lives, produced several products. One is called the Community of Solutions Framework. There's also the 100 Million Healthier Lives Change Library, which is available for free online. And there's also a toolkit, and this is what I'm going to show you today, called Engaging People with Lived Experience. And it will walk you step by step from how to find the right people, how to bring them to your improvement project in your health system, and how to work with them on design, implementation, and evaluation. All of these tools are available through the ihi.org website. And on each of the slides, I'll have the specific link to what part of the toolkit addresses the issue that we are talking about. So in terms of getting started, if you want to revamp your language access program or any other program within your healthcare system, you have to think about, who are the people with lived experience that would participate and add value to this project. What is a person with lived experience, or a PWLE? These are people in the community. They have expertise that comes from their experience, not necessarily from formal education. They have direct experience, a relationship with your system or with the process or issue that you are trying to redesign, or with trying to engage with a particular resource that you curate within your health system. They have awareness from their experience of what works and what doesn't work for them and for others that they know. They also live in the community that you serve, and so they have some awareness about what other resources are available in the community, maybe outside of your organization, but with a linkage to the problem that you're working on. So people with lived experience, they are not necessarily academic experts, but they are experts based on what they have experienced in your community, with your institution, and with the system that you're working on. So how to find the right people with lived experience? First, you have to ask, who is most affected by this issue? In this case, we would be asking, who is most affected by language barriers within our system? Those are the people that you need to bring into the room to work together. Another good question recommended by IHI is, which voices have not been heard? We know that in every community, there are louder voices and softer voices. The louder voices are the activists, and they're constantly telling their story, and they're constantly raising awareness of issues. And those people are essential. We want to have them at the table. But we also want to have the softer voices at the table, people who are affected by the issue but haven't necessarily raised their voices loudly. It's possible that their experience may be different from the experience of the louder voices. You want to have more than just one or two experiences at the table to talk about, the system holistically, and to make sure that what we're designing doesn't work for one or two groups, but for multiple groups that share the system and that live together and coexist in the community. It's also important to ask the question, what do people have? What do they need? What are they ready to grow into in relation to this project of redesign? We want to make sure that the work we're doing aligns with the interests and the resources of the people that we are inviting to the table. So this is brainstorming work that you might do within a healthcare organization before you begin an improvement project, in terms of, okay, who from outside our institution, not an employee, do we need to bring in? Community members, patients, family members, other end users of this service, other folks who have lived experience with the issue. Once you've identified who you need to bring in, you have to go out and find them. And this sometimes means you have to go outside of the hospital, into the community. Meeting with people in the space of their choosing builds respect and trust. We show that their time and effort are valuable. We care so much about their input that we're willing to come to them, at least in the beginning, until we can invite them in to our institution to work collaboratively. Sometimes to build trust, we have to meet with individuals. Sometimes we meet with small groups like focus groups. And it's important to be respectful of people's time, not just in words, but in actions. We might need to offer compensation for the time of the people who are engaging with us in this way, compensation for participating in the focus groups, and ultimately compensation to anyone who's going to engage in a long-term improvement project with our organization. We'll talk more about ideas for where to find the funding for this later, but it's fundamental that people are compensated fairly for their time of the project, just as you, the employee, are compensated for your time, your work on the project. When you're meeting people in the community, as you're about to invite them in, it's important that they know who you are as an organization. It's important that they understand transparently what your purpose is, that you're looking to collaborate and co-design a solution together. And it's important that you spend time getting to know each other before you begin the improvement project. Now, some initial questions for people with lived experience before you begin your improvement project can really help to guide your direction. They can close the gap between what you think is happening on the front lines and what's actually happening, or between what should be happening and what the patient experience or the community experience is. So some of the questions that are recommended in the IHI toolkit, you can find them on a website called communitycommons.org. They include asking these people with lived experience, what are your concerns and priorities? In this case, in relation to language access. What challenges and barriers have you experienced? What resources and assets do you see in the community? What strategies have been tried before? If you're new to your organization, but your patient or community member has lived in that community for a long time, they might have more information than you do. They might have historical context on what has been tried before, what worked and what didn't work from their perspective. A related question that's recommended is, where have people made mistakes in the past that might have caused harm? And it can be really difficult to ask this question and to hear the response. It can be hard because we're so loyal to the organizations where we work, and we're so invested in the work of language access. It can be hard to ask and to hear that maybe people in our institution have made mistakes around language access. And maybe those mistakes have caused harm to that person with lived experience or to someone that they know or love. But it's super important to ask that question so that we don't keep repeating the same mistakes, and so that we show our sincerity in wanting to co-produce something better. Other questions that are helpful are, who else should we talk to or collaborate with to learn more? And what else should we know about the issue? And sometimes community members will tell you, 5 years ago, the hospital did away with in-person interpreting. Or 2 years ago, the hospital switched vendors. Or, we used to have a multilingual menu in the phone system, and now when we call, we only hear the prompts in English. And so they might tell you about things that they valued that were somehow phased out or done away with. Or they might tell you that, the past was better than the current stage. Or they might tell you that no one has ever asked these questions before, and they're very excited that this is the first time that your institution is looking closely with the community at the design of language access systems. We won't know until we ask, and it's really important to ask these questions before we begin to think about what the improvement project would be. So when you're bringing someone from outside your institution, inside your institution to work on improvement, it's important to prepare them for the work. Expectations and hopes need to be clear. There needs to be support for getting the person to the meetings of the improvement group, whether virtual or in person. That might involve making the meeting times flexible, arranging transportation, taking care of childcare. I remember a hospital in the Boston area that was particularly interested in bringing the voices of immigrant and deaf and hard of hearing patients into their improvement projects. And what they found was that they went out into the community, they were transparent about what they were looking for, they found really good people, those people came into the projects, and after 2 or 3 improvement project meetings, the folks dropped out. The patients or family members or community members would say, I'm sorry, I can't make it anymore. My circumstances have changed. Or, my work schedule has changed. I don't have transportation at this time anymore. And that pointed to the need to be more flexible about meeting times and meeting platforms to be able to retain the people with lived experience that were so excited about volunteering their expertise to the improvement projects. If you're only scheduling meetings in the daytime from 9 to 5 when you're at your hospital job, well, most likely you're not going to be able to bring the people with lived experience in because most likely that's also when they're at their job. And so it points to the need for looking at, is an evening meeting better? Is a weekend meeting better? What does that mean for the organization? It might mean having to compensate employees differently, but it's a small investment when you consider the rich returns of being able to involve people with lived experience. And not just the ones that are independently wealthy or have complete control over their work schedules. It's important to ask the volunteers what they need to engage more fully in the design team and collaboratively problem solve to make it happen. Scope and goals for the roll-in project are important. Information about past work and any related work in progress. Your people with lived experience, because they're not, academically trained necessarily in quality improvement, they might need a primer, they might need an overview of quality improvement methods that the hospital uses on all of its projects. And they will certainly need access to the materials that you have access to in terms of meeting minutes, surveys, assessments, resource materials. And there has to be some transparency on the role of each person involved, whether they are staff or volunteer. Now, the people with lived experience, we went out and found them because of their lived experience. And initially, a project might get started as they tell their stories about how they interacted with your system. But it's important to note that when people with lived experience feel that their story is all they have to offer, they might feel obliged to tell it all the time. And if every meeting starts with the same story, you won't be able to progress towards quality improvement. So it's important for them to be made to feel, we can help them feel that they are not just the owner of their experience, but they're also a teammate. And that we're going to help them take on a broader role, and we're going to help them develop their skills in process improvement and in quality improvement, so that they have so much more to offer than just their initial story, although that initial story may have been a catalyst for the improvement project itself. Important to integrate these community volunteers as team members. They might not all feel comfortable sitting in a meeting that involves clinicians and administrators and quality experts and compliance people. Some patients might feel a bit intimidated by that. Remember the louder voices and the softer voices. So you might want to set up a framework for those meetings that incorporates methodology like the plus delta. Plus delta, you may have used this in your hospital. It's a nice way to close out a meeting that gets feedback from everyone in the meeting about what went well and what needs work. So everyone lists at least one plus, something that went well, and everyone lists at least one delta, something that could have been better. That allows you to get feedback from everyone and not just from the louder voices. But even before you get to the end of the meeting in Plus Delta, you want to make sure that your meetings have a facilitator who is going to elicit the participation of everyone, who is going to facilitate in ways that avoid groupthink, who's going to make sure that no one feels so intimidated that they can't express a difference of opinion, and who's going to try to balance all the voices, the people who are quick to respond and the people who might need a moment, the people who naturally interrupt, and the people who take a few seconds when invited to share the airspace, and make a direct invitation to those quieter voices so they can participate as well. Now, in terms of language access, there's other people who might be in these meetings. You're a person with lived experience who is an end user of your language access system may require interpreter services. And so in these meetings, you might have staff interpreters or contracted interpreters to help facilitate the communication. So it's really important that the facilitator be aware of this and collaborate with interpreters on how do we not miss cues that our person with lived experience wants to express themselves or wants to participate or needs a direct invitation to participate or has a difference of opinion. How do we empower them and make sure that we're responding to their voice the same way we respond to the clinician voice or the administrator voice or the compliance person's voice? We want to have equity in the meetings so that we can build an equitable solution. So I know we're going deep now into quality improvement methodology. I don't want to take you too deep, but one thing I do want to show you is that, one of the first things you do when you're looking at redesigning a system is to map out what system already exists. So we don't know if we can't name it, we can't fix it. And we don't know what's broken until we map it out. And so an experience map is an actual physical diagram that's going to show you the patient experience as they walk through the system that already exists. And it can help you find gaps, and it can help point out the pain points of what might need to be improved on. And along with the patient experience, you also want to be mapping the experiences of the other co-designers or the other co-producers, whether they are the clinicians or the clinical support staff in that department or that clinic. So if you map the experiences on a patient journey map, it becomes more evident what works and what doesn't work and what the gaps are and what can be refined. Once you have that map that everyone agrees on, then it's important to agree on priorities of all the pain points, which are the most important to fix. And then you can begin to design a potential solution to one or two of those pain points, but probably not all of them together, because process improvement is really a series of small tests of change. And you want to plan those tests of change and agree together on how you will know that something has changed and how will you know if it is successful. You want to look for metrics that examine the process from the perspectives of everyone that carries it out and the consumer that experiences it, and make sure that the solution worked for everyone. And sometimes it doesn't. And so you want to be meeting again at regular intervals to look at the data, to hear the experience with the change test, and to assess, should we abandon this change? Should we adapt it some way to make it better? Should we adopt it because it really, really did work? And these are conversations you need to have with the same design team and with everyone involved in the tests of change. So what does a patient experience map look like? What you see on screen, and if it's a little blurry to you or a little small, you can access the original on the ahrq.gov site. This is a real experience map that shows you the patient's experience. And this is actually from the Veteran Health Service. And it shows you everything the patient needs to do for their VHA appointment, how they register, what they do before the visit, what they do when they arrive, what they do during the appointment, what they do when they leave, and what they have to do days after. And you can see that it's really quite involved. There are many, many steps that patients have to go through and many, many touch points with the Veterans Health Affairs until they get to the end of that process. Now, the way it's mapped out, this is just a sample. As you look at all of these step-by-step processes, you can identify together what are the bright spots, what's working, and what are the pain points, what's difficult, what's painful, what's challenging to the patient or to the staff. Where could we potentially lose someone? Where could we lose their satisfaction? And you can see at the bottom that they've established priorities. They've picked out certain pain points and said, this moment matters because of X, Y, and Z. And the reasons are provided, by the co-producers of that experience, right? So to walk you through one of these, before the visit, in deciding on the need for an appointment, one of the bright spots is that the veteran can talk to a trusted helper. That's built into the system. The pain points is that they might get incorrect information, or they might have an insurance barrier, or they might not be registered yet. Why does it matter? Well, scheduling can be a barrier to care. If you can't schedule, then you can't get the care. And then what should we measure? Well, one veteran says, we need to measure whether I got the appointment that I needed. So that's just a concrete example of a patient experience map that was done with a specific organization and a specific process in mind. Yours is going to look different in your organization, depending on what process you're looking at, whether it's the language access system design itself as a whole, or how language access supports some other systems design, for example, scheduling in the ambulatory service. Now, when you're looking at language access in a linguistically diverse community, you want to make sure that you're looking at everything, really. You want to map the experience of someone who speaks English as a primary language. You want to map the experience of a deaf or hard of hearing patient. And you want to map the experience of a patient who speaks a language of lesser diffusion, let's say Vietnamese, for example, if that's a major language of your community. And if those experiences are radically different, then you might want to look at how can we streamline them so that we're not making any one group jump through additional hoops compared to any other group. And it's not that the process will be identical, because these are groups with different needs, but the process should not be overly burdensome to one group versus another. So that might be something that your design team looks at together with the people with lived experience. And when you map these three experiences with the same system, you can see the discrepancies and decide, how can we make this better for everyone, and particularly for the groups that seem to be more burdened and have to jump through more hoops when they interact with the same process. So plan, do, study, act, small tests of change. This is fundamental to improvement science in healthcare. Keep asking together, why does it matter? What will make it better? How do we know we made it better? By when should we see improvement? And make sure that all of these conversations happen with the whole group, which will include your people with lived experience. So when you're looking at your resources, you want to cultivate long-term resources. You want to make sure that the people you're inviting in remain connected to your organization. You want to help expand their perspectives, introduce them to other community organizations and resources, cultivate them in leadership roles, invite them to recruit and mentor other people with lived experience, and grow the talent pool. Look at them as potential employees of your organization. And I think organizations work best when every employee is a stakeholder on multiple levels. When you are a community member, a patient, and an employee, then you're really, really invested in how that organization interacts with the community. You have a stake in it, a triple stake, and you absolutely want to make it better. Celebrate those milestones in your improvement projects, whether it's twice a year, quarterly, at the end of the project. Bring together community members, the stakeholders, the community volunteers, highlight the work that was done, highlight the community involvement, celebrate that co-design, and that will in turn lead to more co-design. Involve the people with lived experience, even in the design of the celebration, and in how the results get disseminated throughout the community. So to give you a very concrete example of where this has worked, this is Farah. Farah is a friend of mine. We met at Cambridge Health Alliance, where I worked and where she was the patient and the family member of patients. She's bilingual in Urdu and English, and she began to come to primary care for herself and her family, including for her father-in-law, who speaks Urdu as a language of care. She was recruited in primary care to work as a volunteer person with lived experience in 2014, and she's been in a patient partner role now for 9 years. She's had the opportunity to participate in the co-design of research, quality, and systems improvement projects, and has been able to present nationally on those projects, including a lovely presentation in 2020 that you can watch on Vimeo, called Creating Your Telehealth Platform Hand in Hand with Patients, the CHA Story. We would touch base. We worked together on a few improvement projects, and knowing that I was running the language access program, she would reach out to me from time to time and tell me about her language access experience and say, you know, I brought my father-in-law the other day and all that was offered was telephonic, and I had some doubts about the accuracy of the interpretation. Or I had some doubts about, you know, the integrity of the technology. We experienced issues with connectivity. So she would give this feedback, and she kept saying, we can do better. We can do better for Urdu communities. And that inspired her to attend an interpreter training program herself. She came through the Found in Translation program, which is a Boston-based program that provides 140 hours of free interpreter training to bilingual women. And she's been working now as an interpreter since 2021. She's now a nationally certified healthcare interpreter. She works as a video remote interpreter for one of the large national companies, and she still continues to volunteer her expertise on improvement projects for Cambridge Health Alliance as a patient and as a community member. So I think this is a lovely story of what beautiful thing can happen when we invite the community in and really listen and help them develop their leadership and help them, you know, fall in love with healthcare and in this case with healthcare language access. We're investing in building local resources and local infrastructure. So as you're thinking about this, I know we've presented some, you know, more abstract concepts. I want you to think about what excites you the most about co-production in healthcare. What opportunities might exist locally in your community or in the institution where you work? How can you apply some of these principles to your work in building language access infrastructure? And who might you partner with in the health system and community to get an improvement project started? Who you might partner with depends a lot on where you are and the nature of your relationship with the healthcare organization. If you're an employee, you might look for internal allies first and then extend beyond the brick and mortar into the community. If you're a community activist, you might approach it as a patient and maybe request a meeting with the language access program or with the patient experience office and begin to talk about where you see the gaps in the system and offer collaboration for improvement. As you're thinking about this, you're welcome to put some comments into the chat and about, you know, what you're excited about, where you might apply these principles, and who might you partner with. It's good to brainstorm together. It's okay to start small. You might start with wayfinding and navigation, inviting the community into the project of, you know, what does it look like when you arrive at our hospital? What does it sound like? Is it easy to get from point A to point B? You might look at things like multilingual signage, or even the font size of signage. You might look at language access infrastructure at front desks, or on the phone, or through your hospital's appointment scheduling system. You might choose interpreter modalities and invite people with lived experience to talk to you about their you know, experiences with in-person with phone, with video, and ask them questions about their preferences and what works and whether their preferences change depending on different scenarios and what exists that they like and what you don't have yet that they would like to see. You might even ask them about their experiences with other local health systems in comparison. Is there something that someone else has locally that you don't have that they would like you to have that might cause them to bring their care to you? You might engage them in a project looking at modes. There are now hospitals in California and in Georgia that are giving patients and families options. Would you like to receive consecutive interpretation? Or would you like to wear this headset and listen to a simultaneous interpretation here in the exam room? And some patients will say, yeah, give me the headset. I think it's more efficient, and I'm going to be able to focus on the interpretation and not get distracted by all the other voices. But other patients and families have said, no, I don't want to wear a headset. And also, I do have some English proficiency. I want to hear the provider first and then hear the interpretation, which confirms my understanding. I want to hear all the voices. So, again, like that study in Scotland, when we involve people with lived experience in system design, we are able to give them more options because they tell us, what menu of options would benefit them, as a whole and also individually. You might also start a project on your telehealth platform. At Cambridge Health Alliance, one of the projects that Farah was involved in had to do with, in the pandemic, when we were rolling out telehealth for the first time, we found it easy to conference and interpreters, but patients told us that they found it hard to get into the virtual rooms. And so we worked together with that group to design what was called a skin that would allow patients to enter the virtual platform in their language, to consent for treatment in their language. And we looked at the time, Portuguese, Spanish, and Haitian Creole, which were the most requested languages. And patients said, this skin is helping me get in faster, understand what I'm consenting to. And then once the provider joins, it's always been easy to conference and the interpreter, but thank you for developing, a better interface that works for me as a limited English proficient patient. So we don't know what our community needs until they tell us. And I think the focus in language access in healthcare for so long has been, investing time and resource in building something prepackaged and then saying to the community, look at what we've built for you. Look how much we care for you. Look at what we can offer you. And really, it needs to be the other way. Like Andrea Escalera says, the end users, the people with the lived experience that are interacting with us, they need to be the ones to tell us what is meaningful access, to tell us what they need to be able to access care within our institution in their preferred language. So, concluding comments before we open up for questions. I know I'm a little past my time. Dr. Spatalton said, like any new paradigm, this construct of the co-produced healthcare service, it's still imperfect and it has its challenges, but that doesn't mean it's not useful. And if we look at, the journey, not in seeking new landscapes, but in having new eyes, hopefully we can begin to view our systems as, how they're viewed through our patient's eyes, and consider those different perspectives and together build something better. So Analia, I know that you wanted to open it up for questions.
Yes. Yes, thank you so much, Vanessa. And you can stop sharing if you want.
Sure.
Before I start with the Q&A, I just want to say I loved everything about your presentation and your ending. It is okay to start small. I think it's magnificent. And I want to encourage our participants. They have been just making so many comments and just saying how insightful, how helpful. When you said it is okay to start small, people, my interpreters, you started already today, small, by being here. Now you're informed, you have been educated. So go out and make your dent, make a difference. Never underestimate the power that you have as a community interpreter in your own corner of the world. I am like so inspired, Vanessa. Thank you.
Yeah.
Okay, so I'm going to get started with the Q&A. Okay, One of the questions here says, why and what main reasons are many hospitals downsizing in-house interpreter teams and outsourcing language access wholesale?
Primarily cost. The cost of telephonic interpretation has really been driven down over the past 10 years. And so it's cheaper to outsource than
Mm,
it is to have staff if you look only at the monthly invoices versus the pay stubs. But when you consider
wow.
the return on investment, if you're really committed to health equity, you're going to build up your internal language access infrastructure, and you're not going to let go of your staff interpreters who are also your advocates. We all need partners and vendors that helps us
Yes,
meet the needs of a very diverse population, but we also need to have our internal in-house infrastructure built. It's the interpreters who are advocates who are walking through the hospital saying, that's a good practice, let's keep doing that,
mhm,
and are saying, that's a concerning practice, let's not do that. That doesn't fit with the culture of
exactly.
our organization. So we encourage hospitals everywhere, build up your internal language access infrastructure, involve your local community in the design of your system, and also vet your vendors and get really good partners to support you to supplement what you're able to do in-house.
Absolutely. All modalities are important and they are needed, right? Okay, I'll go to the next question. And before I ask the next question, I just want to let our audience know that if you need to go because you have to go back to work, you have another meeting, etc., you are welcome to be dismissed. You will still get your certificate of completion and the presentation slides. Vanessa has agreed to stay for another few minutes just to answer Q&A, but we just want you to know you are good to go. But if you want to stay, we love you to stay. Okay, next question. Why aren't private medical entities held accountable for providing services that patients will be able to understand and make informed decisions? It will save them a lot of lawsuits.
Oh, absolutely. I think there is more accountability now than there was before. I mean, I've been in the field for more than
Mhm,
25 years. I remember when the Joint Commission didn't ask about language access, and now they routinely ask about it as a component, as an element of patient safety.
mhm,
So I do think there is more accountability now. The challenge really in the US, though, is that there's 50 states doing 50 different things. And unless
mm,
you have a state level legislation that reinforces the federal law, it's really hard to consistently uphold the federal law. To give you an example, I recently relocated from Massachusetts to Florida. And here in Florida, the Florida Patient Bill of Rights actually
mhm.
says, and you can look this up because I'm going to say it verbatim,
Okay.
a patient has a right to an interpreter if the hospital has an interpreter readily available.
What?
What, right? Right. So that
What?
essentially leaves it up to Florida hospitals to decide if they're going to build language access infrastructure or not, which is completely, you know, departed from the federal regulations. So what needs to happen? Juan Palma, who posed the question, mentioned lawsuits. Here in Florida, deaf
Mhm,
patients are suing hospitals for failure to
mhm.
provide adequate language access, and they're winning because they have grounds to win those lawsuits. And
Yes.
usually deaf patients, they're not in it for the money for themselves. They're in it to build better systems. And so
Mhm,
part of the settlement is almost always the hospital has to employ interpreters. The hospital has to start a language access program. And
mhm,
when those language access coordinators arrive in those newly formed positions that were created because of the lawsuits, they realize, oh, wow, it's not just about the care of deaf patients. We have Spanish speakers and Portuguese and Haitian and Russian and Ukrainian. And oh my goodness, we need more interpreters and we need them in more languages. And that's how hospital programs are getting started in places like Florida that really don't have state level protections on language access.
wow.
So yeah, we have to approach this from many angles, but
Mhm.
sometimes it is a lawsuit that gives birth to a movement in a local community.
Exactly.
Yeah. And
Well, and
we
I,
appreciate the patients that have the courage
yes,
to bring these issues forward.
absolutely. And I want to remind our interpreters here in the audience, you make a difference. You make a dent by the way that you excel in what you do. people will recognize, okay, we need our qualified, trained, certified interpreter. Okay, I can go on and on, but I'll just go to the next question. I get so excited. Let's see. How is AI affecting in-house interpreter workforce?
That's a really good question. I mean, we've struggled for a long time with clinicians using, the old go-to, the Google Translate, right? There are clinicians who are using apps on a regular basis and
Mhm.
have for years, particularly in institutions where there isn't internal language access infrastructure. Um, I don't think that will go away. And some of those apps are getting better, but they are not safe
Mhm.
enough to facilitate the clinical communications. And so, really, hospitals need to have policies about the use of AI. In terms of in the broader sense, there is a safe AI workforce or task
Yes.
force that has convened in the past year to begin to look as an industry, as a language access industry, at what guardrails do we want to recommend to policymakers, to legislators, to
Mhm.
hospital administrators, to regulatory agencies around what use of AI is acceptable and what is not in the provision of healthcare. This is work that's just getting started, and we encourage you to visit that website to learn more about it
Yes.
and to volunteer and to help disseminate the work of the Safe AI Task Force.
Thank you, Vanessa. Okay. Another one here. As an interpreter, I support this tremendously, but I can't picture the hospital actually accepting this because they will still say it isn't worth it financially to them. What are ways we can convince people who just only seem to care about the bottom line?
Yeah, yeah. Well, it helps to have physician champions, but I remember talking to someone in hospital
Mhm.
finance who said doctors want lots of things we don't give them because of
Mm,
cost. And so I think
mhm,
more research is needed on outcomes, right? If we're all striving
mm,
towards health equity, then we need to be able to show that outcomes are better. There have been some studies that have shown that when language access is provided by qualified professionals at key points of care, it reduces the readmission rate, right? It
yes.
improves. So we need more of those outcomes. So it's not just about the invoice or the paycheck, it's about what is saved in the long run.
Mhm,
As we improve outcomes for patients, can we lower their utilization of unnecessary services? Can we reduce cost and waste? That's what the team in Scotland was looking at, not specific to language access, but as a general principle. And I think if you do work in a healthcare organization, as you ask around, you'll find that there are people in quality who are
yes.
using these principles on other initiatives. They just maybe haven't thought to apply them to language access yet. So if you can
Mhm.
tie this in with something your hospital is already working on, then it might be easier to get the resources to do the work. But more research is needed to prove that, yeah, human interpreters, certified interpreters, qualified interpreters, specific modalities have a specific impact on outcome.
Yeah, and I love that you keep saying we need more research, and that means we need all of us, right, to come together and to do our part.
Mhm.
Okay, another question here. Deaf patient told me they enjoy VRI because they have more control over scheduling since there is a dearth of on-site. Okay, hmm, I'm not sure
Yeah,
about.
I get
Are you,
that. I get
okay,
that
go ahead. Go
from
ahead.
an interpreter perspective as well.
Yes.
So I worked at Cambridge Health Alliance. We had on-site interpreters. We also had an on-site call center where interpreters were dedicated to phone and video interpreting. I think that video is wonderful. A virtual face-to-face experience. It can be the best of both worlds. It has the immediacy of remote, and it has the visual cues of in person, and it can be wonderful for patients. Imagine a patient
Mhm,
who took time off of work and they only have 30 minutes and they need to get in and out. They don't want to wait for an in-person interpreter. And if the system is not well designed, there can be
mhm.
very long waits. And there might be differences from language to language. So I can imagine, and I have heard patients say, oh yeah, video is wonderful. They press the button, the interpreter is there, as long as the
Yes.
interpreter is qualified and is doing their best work. I think, an interpreter who is skilled with some training can stretch their skill set across the different modalities. It's very much like driving different cars. But a good driver can learn to drive different cars effectively, efficiently, safely. And so I'm glad that patient has had good experiences with VRI.
Thank you, Vanessa. And I will just ask you one more question, and we're going to let Vanessa go. I know she has been so kind and so generous with her time. And someone here is sharing a scenario. It says, I had this crazy scenario recently. Portuguese interpreter is VRI. The LEP patient speaks Portuguese. Teenager daughter is in the room too, and she's bilingual. The provider decides to speak to the patient in Spanish, and if the patient cannot understand, he will switch to English, and the provider will ask the daughter to provide interpretation. Provider says that they got this, and they won't need the certified interpreter. So the question, Vanessa, is how do you politely address the situation advocating for a better language access?
As a Portuguese interpreter, I feel your pain. And in the organization where I worked, the Language Access Department was actually founded in 1978 by a social worker who actually marched down the street to Cambridge City Hall with
Mhm.
2 dictionaries in hand, one Portuguese and one Spanish, to prove to the mayor and the city council that this is not the same language, that they needed to give her
Good.
funding to hire
Awesome.
interpreters for both languages. So yeah, I think that there is scripting that you
Yes.
can use to talk to clinicians briefly and succinctly about it's really important that we communicate with patients in their preferred language.
Mhm.
And their preferred language should be indicated in the electronic health record. And if it's not, then the hospital can redesign its registration processes to capture that information. But if the preferred language is Portuguese, then the interpretation needs to be in Portuguese. If the preferred
Absolutely.
language is Haitian Creole, the interpretation should not be in French. So again, we are co-producing an experience. And if patients have already told us their preferences, who are we to say, no, I got this, I'm going to talk to you in a different language.
It's like,
So
hello.
this may be harder to do if you're not connected to the organization. And this is why
Mhm.
hospitals do need to have their core staff interpreters who can advocate for best practices, and that
Mhm.
benefits the remote interpreters who are contracted to provide services through VRI or OPI. There has to be systems of checks and balances, advocates walking through the hospital saying, okay, that's a good practice, that other thing is not something we do here. We don't
Exactly.
force patients into language boxes that don't fit.
And Vanessa, I tell you something that I just learned a few months ago is that the Portuguese from Brazil is different than the Portuguese from Portugal. And that if somebody wants to be recognized as passing the language proficiency test, they have to pass it in both languages. I mean, not in both languages, in Portuguese to interpret for somebody from Brazil versus somebody from Portugal. I thought that was very interesting.
Well, that's interesting. I don't know if that's universally applied. As someone from a mixed background, my dad is
Mhm.
Portuguese, my husband is Brazilian. I have to
Oh,
say,
interesting.
English has its variations too. Like if I, flew to Australia today, I would understand most things, but not everything. Because there's some differences in terminology, there's definite differences in accent, differences in language utilization. I think that in a diverse community in the US where you have patients from Portugal and Brazil, living in the same neighborhood, maybe working in the same businesses, renting each other's apartments, you need as an interpreter to be prepared to interpret for everyone in the community that speaks that language, and that requires training and it requires
Mhm.
networking. On our team we had interpreters from Brazil and Portugal and Cabo Verde, and they
Okay,
would
let's go Verde.
constantly share information about differences and also about commonalities, and they really helped each other, all of them together, be better Portuguese interpreters.
Thank you. I really appreciate your input, and it's interesting how this company. Anyway, that's another topic. Okay, one more thing before I let you go. I think people will benefit from this. I know that you employ, as you were presenting, LOTE as the acronym instead of LEP. And I know the LOTE is language other than English. And I
Mhm.
know for the last few years, there has been a controversy about using the acronym instead of LEP to LOTE. Could you just share a little bit about that? Because I know you purposely did it. I didn't see the
Yeah.
LEP. So I would love for the rest of the people that are here to learn from what you did.
So, okay, I think that there are different schools of thought on this. So,
Mhm.
there are folks who say, I don't want to use limited English proficiency because I don't want to make our patients feel limited. But the contrasting viewpoint is something that Janice Palma recently wrote about in the Najit blog, and I encourage you to
Okay.
look for that article. She said, well, they need us because there is a limitation. If there weren't a limitation in
Mhm.
their proficiency, they wouldn't need us. And so let's not do away with LEP entirely. It's also what's in the law, and it's very difficult to change the language of the law.
Mhm.
But LOTE is an emerging term, languages other than English, and you'll see it more and more in the literature. And the idea is that it removes any kind of stigma there might be around the term limitation. And it just says, this patient has a different preference. But often it's not just a preference, often it is a need because there is a limitation. So there have been passionate articles written on both sides of the
Yes,
issue. I just use LOTE now more because I think it's more acceptable to everyone. We don't want our feelings, our sensitivities to get in the way of the issues. And so I use the term that is most appealing to
exactly.
the broader audience. But the language of the law is LED. And we want to make
Yes.
sure that we're protecting the language access rights of anyone who has limited English proficiency.
Mhm. And I knew the whole story about behind it, but I wanted you to explain it because, and I love to see that you actually used employed LOTE because that's something I might do.
Mhm.
Okay, it's 12:45. Ladies and gentlemen, thank you so much for joining us this today for this amazing, amazing webinar that Vanessa so kindly and so generously provided for us today. Just a reminder, you will receive within 24 hours an email with the link to download your certificate, and it also will have the PowerPoint presentation that, again, Vanessa so kindly and so generously is sharing with us. So we're so blessed today. And on what? On Valentine's Day, Friendship Day, the love is just going around, Vanessa.
And this is something I'm passionate about. An hour is never enough, and I'm happy to have conversations with anyone who wants to have them. You can reach me at vcosta, VCOSTA, at hcin.org. That was on the final slide of the PowerPoint. You will have
Okay.
access to the PowerPoint as well.
Okay, well, thank you so much, Vanessa. Again, we'll be in touch. I'll see you in Miami in March for the next conference. I look forward to see
That's
you.
right. The Association of
So,
Translators and Interpreters of Florida, ATIF, is having a 3-day conference in Miami, March 15th through 17th. It got approved for ATA, CCHI, IMIA, all the CEs
free
that you need.
promotion, people come, come.
Please come and join us in Miami. We'll have great conversations in a place that needs to have these conversations today.
That's right, in the state that needs it the most. That's what we have discovered. Okay, with that, again, Vanessa, thank you so much again for everything. A wonderful presentation. Everybody has just shared how much they have blessed. They have been blessed today. Thank you, everybody. I will end our presentation for today, and we'll see you on March 13th for our next webinar. Thank you, everybody.
Thank you. Have a great day.
Thank you, Vanessa. Thank you, Andrew. Thank you, everybody. Bye bye.